There are two different types of IUDs. The copper IUD has no hormones and is hands down the most effective non-hormonal reversible contraceptive available. There are several progesterone IUDs. Mirena, Skyla, and Liletta are three brands that you might hear of. This handout from the Reproductive Health Access Project helped women compare the different types of IUDs and determine which one might be the right choice for them. The copper IUD works for longer. It's FDA approved for 10 years, but works for 12 years based on evidence. It tends to cause heavier periods with greater cramping, but this is very tolerable for many women. Sometimes the difference is that they were on a contraceptive pill before and had very light periods, so the difference between a suppressed period on the pill and the heavy periods on the IUD sometimes is not tolerable. The progesterone IUDs cause thinning of the lining of the uterus, so the menstrual cycle will typically seem to stop and there will be no menstrual bleeding at all with the Mirena frequently. This is why we also use it for treatment of heavy menstrual bleeding. Skyla has a lower dose of progesterone and tends to be associated with irregular spotting. Depending on the amount of hormone in the IUD, these progestin IUDs can work for a shorter period of time or a longer period of time. Skyla is approved for 3 years, and we don't recommend it extending the use much beyond that. Mirena is FDA approved for 5 years, but there's good evidence to support extended use to 7 years. Liletta is approved for 4 to 5 years. Now we're going to demonstrate how to place the two different IUDs, the hormonal IUD and the copper IUD. There are a lot of parallels with the endometrial biopsy. We're going to start the same way, getting the patient set up for an intrauterine procedure. We will place the speculum, visualize the cervix, use betadine or another antiseptic to wipe off any secretions that are there. I try to avoid using the phrase, "I'm going to clean your cervix," because I don't want to imply to the patient that I think her cervix is dirty. But the antiseptic solution is a standard practice that we always use. After placing the antiseptic solution, we would place the tenaculum either horizontally or vertically. And now we're going to differ slightly from the endometrial biopsy. With the endometrial biopsy, we can pass the pipelle directly to the fundus and then do the aspiration. And we don't need to measure first because the pipelle essentially does the measurement for us. For the IUD, we need to measure first with what we call a uterine sound. This is a plastic sound, and that's my preferred method. It's very flexible, and I think it's unlikely that we would perforate the uterus with a flexible plastic sound. Metal sounds are also available. Holding the tenaculum in the non-dominant hand, we would then pass the sound gently into the cervical os. There will be some resistance as we pass the internal os, and then we continue to pass the sound until we reach the fundus. You can see with the markings on this sound that this uterus sounds to 7 centimeters. There are a few ways to determine the depth of the uterus. One is you can take a ring forceps, grasp the sound at the cervical os, and remove both together. You could also use a swab of some kind, either a large or a small, line those up and remove both together. I find that if I can't visualize it directly, because I've placed betadine on the cervix, there will be betadine on all the portions of the sound that went into the uterus, and there will be no betadine on the part that went out. So when I remove the sound, there will be a convenient line of betadine at the sounding number. So in this case, again, this uterus sounded to 7 centimeters. We will now set up our IUD for placement. When we open the IUD case, we are not going to touch any of this with our hands. We are going to use no-touch technique. We use no-touch technique for all intrauterine procedures. This means we don't necessarily need to use sterile gloves. We're going to line up all of our instruments so we only touch the handles and we never touch anything that actually goes inside the uterus. The IUD package has a little indentation here, which allows us to move the handle of the IUD so that this slider lands at the same place where we sounded the uterus. So I now have this slider at the 7 centimeter mark on the IUD insertion device. The IUD comes unloaded because the plastic has some memory, and we want it to remember to be in the arms outstretched position. To load the IUD, the hormonal IUD, we move the slider on the handle up away from us. And you can see that as we move that away from us, the arms fold upward, and are now inside the insertion device. We can now place the IUD in the uterus. Again, pulling back on the tenaculum to straighten out the uterus and avoid perforation, we pass the uterus through the external os, through the resistance of the internal os, and move it all the way up. I always move it all the way up to the slider, though really you don't need to go all the way because you're then going to pull back 1 centimeter. Giving this 1 centimeter of space gives the arms room to open. The slider on the handle of the IUD has a mark about 1.5 to 2 centimeters back from the end of the handle. When I bring the slider backward to that mark, the IUD arms open up. So I have only pulled the slider back partway and the arms are open. I am now going to push the IUD all the way up to the fundus in what I hope will be its final resting position. I'm going to hold it there for about 15 to 20 seconds to get used to its position. Once I've held it that long, I can pull the slider the rest of the way down the handle, and that releases the IUD inside the uterus. I can then remove the insertion device and the IUD stays in place. I like to have my scissors ready, and I don't remove the insertion device all the way. Instead, I use it to stabilize the strings while I snip them with my scissors. I'm not going to snip these because this is a reusable model. When it's time to remove the IUD, it's very easy to do so. You take ring forceps, grasp the strings, and pull the IUD down. The patient will experience a small cramp with this, nothing compared to the placement. The placement is quite uncomfortable, but usually asking the patient to pre-medicate with 800 milligrams of ibuprofen is enough to help her get through the procedure. We can also do a paracervical block for patients who are very concerned about the discomfort. The copper IUD has a different insertion process. I think the hardest part about this is loading the IUD into the handle. I find this easiest to do on a flat surface, but I do have sterile gloves available so that if I'm not able to do it through the packaging, I can put on my sterile gloves and do it manually, using, again, fresh sterile gloves to place the IUD into the handle. So instead of the IUD arms extending upward away from the handle, with the copper IUD, the arms extend downward toward the handle. So I'm going to use my fingers to bend the arms backward toward the insertion device. I then pull this tube backward and tuck the tips of the IUD in. So they are now held in place in the IUD handle. The copper IUD comes with a separate stylet, which we place in the insertion handle. I don't put it all the way up because I don't want to accidentally deploy the IUD. The slider on the copper IUD does not have centimeter markings. So you can line it up with your sound to the top of the IUD, not the top of the insertion device, and slide the slider manually up to, in this case, 7 centimeters. Again, to place the IUD, we're going to pass that through the external os. There's a little more resistance at the internal os, and then we're going to bring it all the way up to the fundus. Once the IUD is at the fundus, we push the stylet up through the insertion tube to hold the IUD in place. We then pull the handle backward toward us to release the arms. Now I'm going to push the IUD insertion handle again up to hold the IUD in place. Remove the stylet first, and then remove the insertion tube separately. And again, the IUD stays in place. And I would use the handle to stabilize the strings while I cut them. I usually cut the strings about 4 centimeters long, and over time they will soften up and fold backward around the cervix. If they're cut too short, they can be uncomfortable for a partner. But if they're long, generally the tips are not palpable by a partner. Again, the IUD is easily removed by grasping the strings with the ring forceps and pulling it outward. With this model, the Paragard copper IUD tends to distort in that way. I think that in a real person, the arms would fold backward for it to come out. This is a handout from the Reproductive Health Access Project to help patients understand the progestin implant, which is sold under the brand name Nexplanon in the United States. It is better than the pill, the patch, the ring, and the shot in terms of efficacy. It is also potentially more effective than either intrauterine device. It is officially approved for use for 3 years, but data has indicated that extended use up to 5 years is effective. Unfortunately, that study did not have very many women with a BMI over 30. So we are not totally sure that extended use is effective in heavier women. I'm going to demonstrate how we place the Nexplanon contraceptive implant. This is a great option for people who want long-acting reversible contraception but would really rather not have an intrauterine procedure, which can be really uncomfortable for a lot of people. This procedure only involves local anesthesia. We set the patient up lying on the exam table with their arm extended. Usually we place it in the left arm, but it could be placed in the right arm as well. When we're about to place the Nexplanon implant, we do some measurements to make sure we place it in the right place. When I first used this practice model, we were taught to use a marking pin and mark the skin where we were going to place the implant and where we were going to aim for. I no longer use a marking pin to directly mark the skin because if you place the needle through the marking pin, you can leave a tattoo on the patient's skin, and I don't want to give a tattoo to remind her for the rest of her life of her Nexplanon implant. Instead, I use a usual ballpoint pin without extending the tip. So the tip is empty, and I can press that into the patient's skin and make an indentation at the site where I want to place the needle and at the site that I want to aim for. We have paper rulers in our office that I use for this purpose, but I'm going to demonstrate with this measuring tape. You start measuring at the medial malleolus of the elbow. We're going to assume that that's here. And you want to place the insertion between 8 to 10 centimeters. I measure along the groove, the bicipital groove, and then I angle that down about 2 to 4 centimeters. And I'm going to mark with the pen between 8 and 10, and that should leave an imprint in an actual patient's skin. I then place my guidance marker around 12 to 14 centimeters. I then use an alcohol swab to clean the skin at the insertion site, and I use a thin, small gauge needle that is long, about 1.5 centimeters long, 1.5 inches long. So I place a little bit of local anesthesia just under the skin, and then I insert the needle under the skin along the insertion track, injecting local anesthetic as I go. Once I've placed the local anesthesia, I use betadine or chlorhexidine to sterilize the skin. And then I would usually place a perforated sterile drape to help protect the sterile environment. Once I've tested for local anesthesia, I can open the implant device. It comes in this handle, and I remove the protective cover, and you can see that it's a very large gauge needle to place the implant. I go to the site that I marked. I'm going to retract the skin backward to tighten the skin. Insert the needle at about a 45-degree angle until the entire bevel of the needle is under the skin. Then I'm going to tent up the skin, and lifting the skin, I'm going to pass the insertion device underneath the skin. So by holding the needle upward, the whole insertion device upward, you can see how I'm tenting the skin up. And that helps get the subdermal placement that's not within the fatty layer. Once I've inserted all the way to the hub, I pull back this slider, and that retracts the needle. And then when I remove the insertion device, the implant is underneath the skin. And you can see it here. When I push up, you can see the tips of the implant. With this model, we can remove the skin and see how far underneath the fat I placed the implant. So you can see it's fairly superficial. It went underneath this foam a little bit, but most of it was pretty superficial. I try to have the patient feel that implant location so that she feels comfortable that she can feel the implant. When it comes time to remove the implant, we need a scalpel and mosquito forceps. Again, we sterilize the skin at the distal end of the implant. So I can feel the distal end of the implant right there. I'm going to use a scalpel to make a small incision at the end of the implant. Then I use my fingers to work the implant out of that incision. And this often takes a little bit of working because after the implant has been in for 3 to 5 years, it can get encapsulated with some connective tissue. So with a straight or curved mosquito forceps, once I can visualize the end of the implant, I can grab it with my forceps. Usually there will be some connective tissue holding it in place, and I use the scalpel to dissect that off. Oh, look, there's some. I'm going to dissect that off. And then you can feel when it releases, and then it will come out easily. A new implant can be placed directly through the same hole if the patient wants to continue with this contraceptive method.